Hi everyone, my name's Abdullah. I'll be doing the endocrinology revision lecture for you guys. My email is awar0022 at student dot whatever the rest is. So if you'd like to ask me questions, please feel free to email me or contact me on Messenger. We'll be focusing on the endocrinology system. So it'll mainly be the R1s, and as you can see, there's quite a lot of R1s. And as you may be aware, there's quite a lot of overlap between the cardiology section, so especially hypertension, diabetes, hyperlipidemia in particular, as those are part of the cardiovascular risk factors that you want to know about. Then we'll also be covering thyroid disorders as well as osteoporosis. I'd also like you to note that a lot of these R2s and R3s actually come under the hypertension topic. Um, but for the R2s and the R3s, we won't really be going into as much depth. And the uh, lecture is really, I'll try and make it short and try and focus on the main parts. If you'd like some more information, the like there's more in-depth resources that you can use on the Mumis Drive. So I'd encourage you to have a look at those. We'll start by having a look at hypertension. So with hypertension, essentially high blood pressure. But what is a high blood pressure? So we'd say that more than 140 by 90 is hypertension. You wouldn't start treating, however, until 160. So once you've got that reading of 160, you'll actually start medical management, and we'll go into what that is. You're going to target 140 by 90 unless they have high risk features. And by high risk, we just mean what someone would be high risk for cardiovascular disease. And in that case, the Australian guidelines recommend aiming for 120 by 80. Um, it's also important to note that if you are in clinic and you see high blood pressure, you wouldn't start blood pressure therapy straight away. What you want to do is put them on 24-hour ambulatory blood pressure monitoring. That would be the gold standard. If you can't do that, you can also do like regular checks. So they might have a blood pressure monitor at home or at the pharmacy that they can go to and use. So again, cardiovascular is disease risk, peripheral vascular disease, and CKD. These are all, and this is essentially the reason as to why we want to control blood pressure. Um, CKD, the main cause of CKD are high blood pressure and diabetes. So we'll have a look now at what is essential and secondary hypertension, as well as what the key agents are to use. And so I've already stated that 24-hour ambulatory BP monitoring is required. You don't want to just rely on that one clinic measurement. What you actually want to do is see how they are at home, because it might be white coat hypertension, which is essentially where someone goes to the doctor. They get maybe a little bit stressed or have a bit of anxiety, um, and that causes their blood pressure to be raised when normally it wouldn't be that high. So I'll ask you to think about what some causes of secondary hypertension are. There's a few different systems that are involved in this, but it'd be good if you can pause and just have a think about what these secondary causes might be. So the way that I think about it essentially is from head to toe. So you can think endocrinological, so like pituitary gland or thyroid gland, and then the adrenal glands. Uh, so pituitary, thyroid, adrenal. So the renal artery stenosis is essentially a bit of a different mechanism, where it's not necessarily hormones itself, but the renal artery gets narrowed, and due to that, it activates the renin, angiotensin, aldosterone system, because the kidneys are being there's less blood essentially going to the kidneys. So the kidneys, in a very simple explanation, think that there's less blood volume in the body, and so they'll increase renin, and that will cause more water retention or more retention within the body, and that causes the blood pressure to be high. Hyperthyroidism, again, it increases thyroid hormone, OSA. There's an association between OSA and high blood pressure. Pheochromocytoma, so this is one of those arteries that I was talking about. Essentially, it's an adrenal adenoma that will release catecholamines, or like essentially things that will drive the sympathetic nervous system. And it generally presents with periods of anxiety, headache, high blood pressure, and it generally has fluctuating symptoms. So that's the sort of buzzword presentation, if you will, for pheochromocytoma. Conn syndrome, or primary hyperaldosteronism, and that's essentially where you have too much aldosterone. So there's it's a primary problem with the adrenal gland making too much aldosterone, and that will cause the retention of sodium, or sorry, the retention of water in the body, and that will increase the blood pressure. Cushing syndrome, again, that's when you have too much cortisol in the body. That can be due to Cushing's disease, which is where the pituitary gland is secreting ACTH. It can be due to steroids, and there's also some cancers, such as lung cancer, that can cause Cushing syndrome as well. Lastly, there's coarctation of the aorta, which is quite rare. Essentially, it's where the distal end of the aorta will get narrowed, and that will cause a high blood pressure. So it's good to know what some of the investigations are for these, and I've got those here on the next slide. Um, so you can use imaging for the renal artery stenosis. Hyperthyroid is quite simple with the TFT. Sleep study for the OSA, and for the pheochromocytoma, you want to look at the plasma metanephrines, and then you can also do some further investigations such as a CT, and then a venous sampling as well. The definitive management, I don't really think you need to know for pheochromocytoma because it's an R3, so I won't go into it. For the primary hyperaldosteronism, you would perform an angiotensin, uh, sorry, aldosterone renin ratio, um, or an ARR. Um, with this, essentially, it's just looking at the ratio of renin to aldosterone, and there are some contraindications or some absolute contraindications as to when you would perform the test. So, for example, if someone is on spironolactone, which is an inhibitor, that might be a reason as to why you wouldn't perform the test. For Cushing syndrome, there's a few different tests. The confirmatory test would be dexamethasone suppression test. And for the coarctation of the aorta, I said it's something that you would suspect on examination. And then you can do some further imaging tests as well. So next we have essential hypertension, and that's just defined as hypertension that does not have any other cause. So um, I'll allow you a moment to pause just to think about what the best management options would be, or what three drug medication options there are for managing hypertension. Okay, so those three options are ACE inhibitor, calcium channel blocker, and thiazide diuretic. When you're thinking about which one you want to use, think about the side effect profile as well as what some of the other benefits might be of using that drug. In particular, for ACE inhibitors or ARBs, they are good for blood pressure, yes, of course, but they can also be used in ischemic heart disease, in heart failure, and they're also renoprotective, so they have a range of benefits. With calcium channel blockers, you probably want to avoid in heart failure because they're going to decrease the contractility of the heart. And the thiazide diuretics, they do have some side effects, but I don't really think it's something that you particularly would place like that much of an emphasis on when you're just choosing for blood pressure. But if they have other comorbidities, then you probably want to consider that as well. Okay, so for the ACE inhibitors, their side effects are, as you are hopefully aware from previous years, dry cough and angioedema. The ARBs don't have that effect of dry cough or angioedema, and so you might actually prefer to use an ARB first line. Uh, you should know that they can cause hyperkalemia. So if someone's on an ACE inhibitor and they have hyperkalemia, you might want to inform them about reducing potassium supplements, and you want to be managing that. There's a common exam question about how to manage hyperkalemia. So you would use calcium gluconate for the cardiac myocytes to stabilize them, rosonium, which is a chelating agent, which will remove potassium from the body, as well as dextrose and insulin. So dextrose and insulin is essentially there to drive potassium inside the cells and to reduce hyperkalemia, or to reduce the potassium level, sorry. You also want to be quite careful using ACE inhibitors or ARBs in bilateral renal artery stenosis because that can precipitate an AKI. And then so we have the DHP and the non-DHP calcium channel blockers. Their main side effect would be leg swelling, and you also don't want to be using them in decreased cardiac contractility. The DHP ones will typically cause the leg swelling because they act more peripherally, whereas the non-DHP ones will cause will act primarily on the heart. So you won't want to use those when there's decreased cardiac function already in HFrEF. Okay, and then lastly we have thiazide So these will cause hyponatremia. So you want to be quite careful using these in the elderly. And the other side effects that I mentioned were that they can increase the risk of gout and can also increase cholesterol levels. If someone does have gout, you want to be quite, maybe you can consider some of the other options. So then we also have some second line options, and so this is where the beta blockers or the alpha blockers come in. You want to The main side effect of the alpha blockers would be the postural hypotension that they can cause, and so you have to be quite careful when using them in an elderly population. So I would really emphasize the importance of knowing the first line management of hypertension. So, as expected, you start with one agent. However, if that doesn't work, the best option is actually to add another agent rather than increasing the dose. And if that still doesn't work, you can also consider secondary hypertension. So, you consider secondary hypertension if they have features of secondary hypertension. So, if they have features that might be consistent with hyperthyroidism, for example. Um, and also if it's someone who's younger. So if I think the age cutoff, I don't think you need to know, but it's, if they're less than 50, less than 55, and they have high blood pressure, you can consider secondary causes. Um, and especially if they have well-controlled blood pressure that then becomes difficult to control or requires multiple different medications to control, you would want to be investigating for the causes of secondary hypertension that I mentioned previously. We'll talk about this later as well, but with cardiovascular risk, you want to consider those three that I've got here, as well as smoking and family history. In particular, familial hypercholesterolemia is a significant carries a significant risk of cardiovascular disease. So now that we've talked about high blood pressure, we'll start to talk about diabetes. Again, I'm trying to focus on what I think are the most important things that you need to know for your exam, keeping in mind that you'll probably have, maybe 5 to 10 other videos to watch um, for your different matrix topics. So we'll talk about the different types of diabetes first. We have type 1 diabetes, where it's an autoimmune disease, where the beta cells of the pancreas are attacked, and that leads to a lack of insulin. In type 2 diabetes, it's a different problem. Um, it's the problem is with insulin resistance, so the body isn't responding adequately to insulin, and therefore the glucose levels in the blood will build up. There's also other causes that you probably don't need to know as much about. There's LADA, which is latent autoimmune diabetes in adults. It's quite similar to type 1. However, the key difference is that the disease onset is later in life. In MODY, it's more similar to type 2. It has a genetic association. And then there's other causes. So, for example, chronic pancreatitis due to the damage to the pancreas can cause endocrine dysfunction, and that can also lead to diabetes. Cystic fibrosis is also related, and Cushing syndrome and acromegaly. Essentially, in Cushing syndrome, it's cortisol. In acromegaly, it's growth hormone. They will cause the glucose levels to be high due to the endocrine effects of those hormones. When we're comparing type 1 versus type 2 diabetes, you might have learned that type 1 is typically in a younger person, but that's not always the case. Type 2, there might be a family history of type 2 diabetes. They might have a higher BMI. Um, but I think you also have to look at I mean, you wouldn't just rely on the history, you would also want to do the investigations, which we'll get to in a minute. In type 1, you particularly want to look at their family history. So they might not have a family history of type 1, but they might have a family history of Graves' disease or celiac disease, rheumatoid arthritis, or Addison's disease. And the reason is that these are all sort of, somewhat related. Um, when it comes to autoimmune diseases. So you can ask about these different autoimmune diseases, and if they do have these autoimmune diseases, that would increase likelihood that they might have type 1 diabetes as opposed to type 2. So it's important that you know how to diagnose diabetes, and I think that this is it's a very easy mark to get on the exam. So if the HbA1c is more than 6.5, if the random BSL is more than 11.1, and if the fasting BSL is more than 7, that's when we would get quite worried that you could have a diagnosis. But unless it's the random BSL, you want to have ideally at least two tests that are high to be able to diagnose diabetes. Um, And as we were talking about before, the investigation that you do to distinguish between type 1 and type 2 is a C peptide. The C peptide is made by the body. So when the body makes insulin, it will make the C peptide. Um, because if you just look at the insulin, there's no way for us to actually distinguish whether it's endogenous, so the insulin that the body has made, versus insulin that has come from outside the body. So if someone's been using insulin, for example. So the C-peptide is how you distinguish whether it's type 1 or type 2 diabetes, based on whether or not the body's actually producing its own insulin. The complications of diabetes you may already be familiar with. So for the microvascular, it's the pathies, I guess. So peripheral neuropathy, retinopathy, and nephropathy. For macrovascular, it's the bigger arteries. So ischemic heart disease, so coronary arteries, cerebrovascular disease, and peripheral vascular disease as well. Then there's also autonomic dysfunction. So that would be erectile dysfunction and postural hypotension. Um, and we'll talk a little bit about what some of these complications mean in terms of, like, I guess, some of the outcomes as well. But as a general rule, in type 1 diabetes, the onset is often earlier. So, especially in retinopathy, they might have the retinopathy onset much earlier, maybe even by years and years, as opposed to type 2. But the biggest risk factor would probably be when it's poorly controlled diabetes. And that is obviously going to be a big risk factor. So we'll talk about peripheral neuropathy and Charcot's arthropathy. So in peripheral neuropathy, what happens is that it's a glove and stocking distribution loss of sensation. So um, they might lose the sensation in up to their toes, or perhaps up to the ankle, or perhaps even higher. And it's bilateral and it's ascending, so it moves up the foot, and that also loses sensation in their hands, and that can be quite problematic because if you note the way in which they walk, if they can't really, if someone can't sense, if they lose a sensation when they're walking, uh, they might hit their foot against the ground quite hard, and they might not even feel that. And over time, that can lead to microtrauma that causes the structure of the foot to change. So as you can see here, in a normal foot, you would have the arch, the bony prominences are normal, um, but with these chronic changes or with this microtrauma over a period of time, the arch of the foot is lost, there's clawing of the toes, and these bony prominences will become more prominent immediately. And what that leads to is pressure being applied on the foot where otherwise it shouldn't be or it wouldn't be. And that can increase the risk of breaks, and it can cause ulcers, so neuropathic as well as arterial ulcers, because again, there's also often going to be coexistent peripheral arterial disease as well. So when you're doing the diabetic foot exam, you would test for sensation in these spots, as well as a vibration sense. So that's, I guess, why you do it. And so this phenomenon is called Charcot's arthropathy. The big risk with this, and the fact that it can cause ulcers, is the risk of osteomyelitis, which may lead to amputations, for example. So that's one of the big risks that you have to think about, as well as the combined risk, I guess, of the peripheral neuropathy having poor sensation, as well as the peripheral arterial supply not really supplying a lot of blood to the foot either. And as for the investigations for diabetes, I've already mentioned the autoimmune diseases, but you also want to do the FBE alongside the HbA1c, because the HbA1c is essentially the glycated hemoglobin, so how much essentially sugar there is in the blood. But if someone's had blood transfusions or if they've had hemolytic anemia, um, renal disease or liver disease, that's going to influence the HbA1c. So you want to make sure that the HbA1c that you're looking at is actually an accurate value, because again, it will be impacted by diseases that impact the blood. You also want to test for UECs and LFTs. So UECs for nephropathy, look at the eGFR, and also for fatty liver, which is another which can also be included in, or which is also a risk as part of that metabolic syndrome. You also want to look at proteinuria and albuminuria. So albuminuria is an independent risk factor for cardiovascular disease, but it's also a marker of diabetic nephropathy. So if they have diabetic nephropathy, you want to manage that. So again, you would use ACE inhibitor as first line, SGLT2 inhibitor as second line, and finerenone as third line. But that's something that the renal lecture will cover in more depth. So for the management of type 1, essentially, quite widely, you might just know this as insulin therapy. There's different types of insulin therapy though, but the main one that you need to know is basal bolus. So basal bolus just means there's long acting that they take uh, regularly, and before meals there will be that short acting insulin as well. Then there's also mixed insulins. So those are a combination of long and short acting. Those aren't really used in type 1 diabetes. And the main regimen is basal bolus with long and short acting. So they might have long acting at the start of the day and then short acting before their meals. Um, and then I also would just like to bring up the idea of the best control will be on the continuous glucose monitor and the insulin pump. So the continuous glucose monitor is here, it's a sensor. The sensor will detect what the glucose levels are. The insulin pump will then pump the correct amount of insulin into the blood. So this is all managed with these devices, and that'll provide the best control. And then it can also be uploaded to the smartwatch or the smartphone, and in clinic, the clinician can actually look at it. Okay, so for the management of type 2 diabetes, you have a few different options. Always would start with metformin, and then you can consider some other options. So I think the first three are the main ones. Sulfonylureas, I don't really see them used as much, or at least I haven't in my experience. And the guidelines do recommend the use of SGLT2 inhibitors or DPP4 and GLP-1 if there's a high risk of cardiovascular disease or atherosclerotic disease. SGLT2 inhibitors are also useful in diabetic nephropathy, as I've already mentioned, as well as in heart failure. The DPP4 and the GLP-1 inhibitors shouldn't be used together because they have essentially the same mode of action. The most useful thing, or I think one of the most important things, is that you know how to, or that you know what the side effects of each of these medications are. And you might have seen some really big tables, but what I've tried to do is summarize the main things that I think you should know. So the two main drugs that will also result in weight loss are um, right, sorry, GLP-1 and the SGLT2 inhibitors. Metformin is weight neutral, and as we'll get to later, sulfonylureas are related to weight gain. The side effects of metformin that you should know are lactic acidosis and B12 malabsorption, and the SGLT2 inhibitors have urosepsis and euglycemic DKA. This is one of the reasons as to why these two medications are ceased prior to surgery, and that's something that the critical care lecture might cover. I've already told you one, but maybe you can have a think about what the other side effect of sulfonylureas might be. And so that's hypoglycemia, especially in kidney disease. So what happens is that because the sulfonylureas are excreted via the kidneys, um, there will be more glucose lost via the kidneys because the sulfonylurea builds up. However, that isn't desirable because if it causes hypoglycemia, that can actually be quite dangerous. And then we have the side effects of the GLP-1 agonists. So I'll give you a moment to think about what the side effects of those might be, as I probably should have done for the other ones as well. So those would just be pancreatitis and GI disturbance. So it will cause nausea, and if someone tries to keep taking the medication despite causing nausea, they will start to vomit. And then pancreatitis is another risk as well. So um, that's why you start low and then gradually increase the dose. And you might have seen insulin used in type 2 diabetes. That's more if if it's later on, because insulin will cause weight gain, and that's not desirable in type 2 diabetes. All right, so we're almost halfway there. So I know that I said I'd try and focus on the main thing, so I'll try and do that a bit more. Um, but so when it comes to hyperlipidemia, basically There's two things. There's disorders of cholesterol and disorders of the triglycerides. The importance of that distinction is that the management of them is actually quite different, so you'd use different drugs. Again, there's some secondary causes, and I'd encourage you to pause and think about what some of those secondary causes might be. Okay, so hopefully you've thought about them. The secondary causes include nephrotic syndrome. Again, you're losing in nephrotic syndrome, albumin gets lost or protein gets lost. And as a result of that, the liver will increase the production of the proteins that carry cholesterol around the body, and that will increase the lipids in the body. The other causes are hypothyroidism, so it decreases the basal metabolic rate. And by decreasing the basal metabolic rate, less lipids are broken down, and so lipids build up. Cushing syndrome, essentially, again, cortisol has an impact of increasing lipolysis, and that will cause hyperlipidemia. Connective tissue diseases such as SLE and RA, rheumatoid arthritis are also implicated. OSA, again, hypertension, hyperlipidemia also has an association with those two. And then type 2 diabetes can also cause or be associated with hyperlipidemia. Um, when we talk about absolute cardiovascular risk, this is what I was referencing before. If someone has hyperlipidemia, hypertension, and diabetes, uh, it's a different risk as compared to if they just had one. So when you look at the absolute cardiovascular risk, that's the chance of a cardiovascular event occurring in the next 5 years. So a cardiovascular event might be like a heart attack or a stroke, and it's based on multiple risk factors, and it's expressed as a percentage. So if someone has a 5% risk, that might mean that they have sorry, that means that out of 100 people like that person or with the same risk factor profile, um, five of them would be expected to have a heart attack or a stroke in 5 years' time. High risk is defined as more than 15%, and intermediate risk is defined as more than 5% or more. And some of the risk factors that I've mentioned are proteinuria, CKD, postmenopausal, smoking, connective tissue diseases, essentially those causes that I was mentioning before. Smoking is another risk factor. And I'd also like you to think about the risk of familial hypercholesterolemia. So these are those, the tendon xanthomata and the xanthelasma that you would look for in the cardiovascular exam. If someone has these, they are already at a very, very high risk of cardiovascular disease. The complications, we've already talked about cardiovascular disease. It's also associated with a risk of pancreatitis. So the two most common causes would be gallstones and alcohol, but hyperlipidemia can also cause pancreatitis. The non-pharmacological management, I'm sure you're all familiar with, and then the management of hyperlipidemia. So we're going to talk about hypercholesterolemia first. So the first line agent is, and I'll ask you to think about what each of the agents do and what their side effects are as I go through them. So the first line agent is a statin. It's a HMG-CoA reductase inhibitor. The main side effect is rhabdomyolysis, and it also causes hepatotoxicity. So for the hepatotoxicity, you just want to test LFTs. Um, ezetimibe. So the particular benefit of ezetimibe is that it's good for reducing the LDL-C, and its mode of action is that it reduces cholesterol absorption at the small intestine border. Cholestyramine, it reduces the enterohepatic circulation of bile acids. Bile acid contain cholesterol, so if you aren't able to recycle those bile acids, you have to use up more of the cholesterol in the body. And I'll ask you to think about one of the side effects of cholestyramine would be. It's just GI disturbance. So we have the PCSK9 inhibitors. These are more typically used for when you have higher risk cases or when the other therapies don't work, particularly in familial hypercholesterolemia, to my knowledge. So essentially, the mode of action is that they inhibit the PCSK9, you can probably tell from the name. And what that does is that it prevents the breakdown of these LDL receptors. And so the LDL receptors can stay there. The LDL can come inside the cell, or essentially that brings the cholesterol inside the cell and reduces the hyperlipidemia. Um, the management of hypertriglyceridemia, as I mentioned, is quite different. There's three main agents: fenofibrate, niacin, and fish oil. The niacin is quite poorly tolerated. It causes flushing, and um, uh, it's not as good, or it's not as well tolerated. The fenofibrate works via the PPAR alpha inhibitor, and may also be used or it may also slightly decrease the glucose level. So, in someone who has type 2 diabetes and hypertriglyceridemia, fenofibrate might be a good option. Um, I'll also quickly just touch on primary and secondary prevention. So, for the primary prevention of hyperlipidemia, you can use statins. However, if someone's already had a cardiovascular event, so they already have ischemic heart disease, primary prevention is no longer adequate, or because again they've already got the disease. So we'd use secondary prevention. And the drugs that they should be on if they've already had an ischemic event or a stroke would be statin, aspirin, beta blocker, and ACE inhibitor. And hopefully that's something that you've seen this year on your placements. Uh, we'll now touch on osteoporosis. Osteoporosis is defined as decreased bone density. The main investigation that we'd use is the DEXA scan, which will look at the bone density. In older population, you use the T-score. In a younger population, you use the Z-score. So the T-score of less than minus 2.5 is defined as osteoporosis. Any more than that, it would be osteopenia. And then, of course, there's normal as well. But we'll just look at osteoporosis. In a younger population, the reason that you might use it is because, or you might use a Z-score, is due to if someone's on steroids, for example, for an autoimmune disease. The two biggest risk factors for osteoporosis is postmenopausal women as well as age. And then the other risk factors that I mentioned is steroid as well. So there's some protective factors such as weight resistance, so weight training. Walking can also be quite useful. And then sufficient vitamin D and calcium are important for strong bones. Um, to reduce their risk in an elderly person, for example, you'd want to reduce their risk of falls and also want to use those protective factors that I mentioned previously. In osteoporosis, people typically have uh, low trauma pathological fractures. So there might be a normal amount of force, but because the bone is weaker, that might actually cause a fracture. And typically you'll notice there's the osteoporotic fractures of the vertebral bodies as a common exam question. So there's some diseases that are associated with osteoporosis as well. And these include hyperthyroidism, hyperparathyroidism, multiple myeloma, and malabsorption diseases like celiac disease or IBD. The mode of action essentially here is that they impact on the calcium and the vitamin D balance in the body, and doing so will increase the risk of weaker bones. The complications, as I mentioned, is those low impact fractures. The typical exam question is those vertebral body or that loss of vertebral body and that loss of height. Oh, sorry, loss of height, and the vertebral body fractures. And so the key investigations really is just that DEXA scan and then screening for those diseases that I mentioned previously. For medication, you have anabolic therapies, anti-resorptive therapies, and hormone replacement therapy. However, hormone replacement therapy is something that is not indicated for osteoporosis alone. It's something that's used more in the management of menopause, which is not part of the E3 matrix, and so we won't discuss it any further. The anti-resorptive agents, you use those when the anabolic agents don't work. And the anabolic agents are the main ones. We'll cover those just now. So the two main risks that you want to know for bisphosphonates and denosumab are atypical fractures. So fractures, I guess, I mean, it's kind of in the word you wouldn't expect, like femoral shaft fractures in particular. And these fractures can often be quite more problematic and harder to manage. And the other complication is osteonecrosis of the jaw. The difference between denosumab and bisphosphonates. So, denosumab is a 6 monthly subcutaneous injection. Bisphosphonates are oral or IV, and their oral side effects can cause esophagitis. Also, sorry, the um, the oral formulations can cause esophagitis, so the patient has to sit up for 30 minutes after taking it. Um, and once someone's on a bisphosphonate, they require an adequate plan to actually get off of the bisphosphonate, or there will be an increased risk of fractures after they've been on the bisphosphonate. Um, and the other benefit of denosumab is that you also don't have to adjust that dose in renal disease, adjust their dose in renal disease, and that can also be another benefit. Um, Okay, we'll talk about hypothyroidism now. So as I mentioned, we don't have much left, but I'll try and cover the main topics so that it's hopefully useful for you for your exams. So for the hypothyroidism, basically the management is with levothyroxine or essentially replacing the thyroxine. It might require titration, but that's more of a specialist thing that you won't need to worry about for your exams at least. The symptoms are weight gain, cold intolerance, constipation, decreased cognition, and the complications are hyperlipidemia, as I've mentioned before, anemia, and cardiac failure. There's a few different causes. The is mainly a viral cause, and Hashimoto's is an autoimmune cause, and you want to test the two antibodies, anti-TBO and anti-TGAB, as I've mentioned there. And in hypothyroidism, there's a few different causes. I think the most important one for you would be Graves' disease. And so you'd want to test the antibodies for Graves' disease, which would be the TSH receptor antibody. The complications, as I mentioned previously, osteoporosis, cognitive dysfunction when it's thyrotoxicosis. That might be seen in an elderly population or an elderly person who presents with the features of thyrotoxicosis. So they might have, like palpitations and have very high mood. The management is with propylthiouracil or carbimazole, and other options include radioactive therapies and surgery. For propylthiouracil and carbimazole, the main side effect that you need to know is, well, I'll let you think of it for a little bit, so you can pause if you like, but the main risk is agranulocytosis. Agranulocytosis essentially means that their granulocytes or their immune cells are low, and in that case, what you would want to do is inform them that if they do have a fever, they should get an FBE done, and that FBE is to check for their granulocytes, particularly their neutrophils. We also mentioned thyroid surgery. We won't really cover in too much depth, but thyroid surgery can damage the parathyroid gland, and that can cause hypoparathyroidism. It can cause a recurrent laryngeal nerve damage because the recurrent laryngeal nerve just runs along here and is also quite close there. And it can also cause hypercalcemia, again related to the hypoparathyroidism. It can be, however, transient. Another risk is if there's bleeding, um, it can cause a hematoma and it can constrict the or compress on the trachea. And in that case, you would want to cut the sutures. That would be a more of an immediate postoperative complication in the first few days. We'll also talk about hypoparathyroidism, so stones, bones, thrones, groans, and psychiatric overtones. You might have heard of this. So the stones refers to like renal stones. Bones refers to osteoporosis or like that bone pain that they might have. Thrones refers to that urinary frequency and constipation. Groins, it can refer to um, pancreatitis or peptic ulcer disease that can be associated with hyperparathyroidism. And the psychiatric overtones refers to the confusion that may be associated with hypercalcemia. We'll also talk about primary versus secondary and tertiary on the quiz day. But essentially, the difference between primary is that it's the PTH is too high, versus secondary and tertiary. So those are associated with renal hyperparathyroidism, and so whilst the PTH is high in secondary, the calcium will be low, and tertiary, the calcium will be high. So just in case you're a little bit confused, I'll repeat that. Primary PTH and calcium high, secondary PTH high, calcium low, and then in tertiary, it's just when secondary's gone on for so long, the parathyroid gland just completely takes over, I guess, and the PTH will be very high, will be high, sorry, but now the calcium will also be high. Um, There's also diabetes insipidus. Essentially, it presents with polyuria and polydipsia. So those are some of the those can be the presenting symptoms of diabetes. However, here it's not a problem with diabetes; it's a problem with ADH. Either the body is not the body's response to ADH is inadequate, and that can be either at the level of the kidneys or it can be due to production of ADH. Um, in SRADH, essentially it's a syndrome of inappropriate antidiuretic hormone. It can be associated with some tumors, so as lung cancer, small cell lung carcinoma, medications, and infection. Um, Essentially what happens is that the ADH will cause the body to hold on to water but not salt. And so if you think about it, if the body is holding on to water, but it's peeing out sodium, the sodium content in the urine will be high and the sodium content in the blood will be low. Next, we'll talk about Addison's disease. In Addison's disease, it's a primary hypoadrenalism. It's associated with pigmentation. However, if it was a problem with the ACTH, so here with the adrenal glands will release cortisol and um, the adrenal gland will also release those other hormones. But if the problem is with ACTH, there wouldn't be pigmentation. But in Addison's disease, you would expect to see pigmentation. Uh, the ACTH, because the cortisol is high, the ACTH will be low. Um, However, if it was the ACTH, if it was secondary hypoadrenalism, you would expect the ACTH to be low and the cortisol to be low. Addison's disease can be a life-threatening, or the Addisonian's crisis can be life-threatening, and that the causes of that are essentially times of stress. So it can be psychological stress as well as physiological stress, such as surgery. The treatment is with steroids, mineralocorticoids, and fluid resuscitation. And lastly, we'll talk about Cushing's syndrome. So Cushing's disease is with pituitary, it's essentially, as I mentioned previously, pituitary adenoma secreting ACTH. So in the pituitary, there's an adenoma that will secrete ACTH. With Cushing's syndrome, it is essentially just when your cortisol is too high. Its complications, that it has a lot of complications. I've mentioned the main ones, and I've hopefully emphasized that it can cause hypertension and hyperglycemia or diabetes throughout. And there's also some other associations that are there on the screen there. And the confirmatory testing is with the dexamethasone suppression test. Um, that brings us to the end, and I understand that it was quite long, and I hope I didn't bore you too much. There's also a QR code, and that if you have the time to, I'd appreciate if you provide me with some feedback, as well as any topics that you think I didn't cover adequately. So we can cover those more on the exam day, or on the quiz day, sorry. And I will also acknowledge I didn't really go into full depth on a few topics, um, but I hope that I covered the main topics for you and that I covered those topics, the core topics, to sufficient detail. So I'd encourage you to provide some feedback and to ask any questions, and so you'll have that opportunity on the Google form. And I look forward to seeing you on the quiz day. Thank you very much.